All right, welcome back to the show. I'm your host, Dr. Daria Hamrah, and today's episode is going to reshape how you think about weight loss, hormones, and your health. Joining me is Dr. Rocio Salas-Whalen, a triple board certified endocrinologist and obesity medicine expert based in New York City. She's a global voice in metabolic health and obesity. Today, we're going to talk about hormones and hormone disruptors, demystify GLP-1s, talk about why most diets fail, unpack the myths around obesity, and highlight how modern medicine is empowering people to take back control of their health. So, Rocio, thank you so much for coming on. And I'm going to hit it off with the first question. We're going to dive right into it. Um, what is actually obesity? We all heard the word obesity. People have this image of what obesity might mean. Probably a really super overweight person. And we hear it in the news that is kind of like the pandemic. 70% of Americans are obese. But what's the definition? As an endocrinologist and obesity medicine physician, can you please define it so for the sake of this conversation today, we can have a basis.
Definitely, I think so. Obesity is a disease of the fat tissue. Basically, it's a disease of adipose tissue, right?
So it's a
But
medical condition.
it's a medical condition that there's an excess of fat tissue that can cause or causes disease, right? Fat tissue is pro-inflammatory, so this can increase the risks for metabolic disease, type 2 diabetes, even more than 13 type of cancers that are related to this excess of fat tissue of what we call the bad fat, right? Which is like visceral fat.
Hmm.
Um, and the also definition of obesity is it's a chronic multifactorial disease, right? And when we talk about chronic, meaning that it is long term, like other chronic diseases that we have, type 2 diabetes, osteoarthritis, hypertension, they are not curable, they're controllable. Multifactorial, that there's many different factors that can contribute for this disease or for obesity. Um, and this is a definition of obesity.
So if a lot of people have heard of the fact that fat causes inflammation, but fat, we have it in our body. Can you clarify for people what that exactly means? That not having fat is not a bad thing, but then too much of it, how too much of the fat causes this type of inflammation. And and
Yeah.
then and then how do you know too much is too much?
So we have brown fat, which is what we consider a good fat, right? Is thermoactive, and then we have the white fat, what we consider dangerous. And fat tissue is an active tissue. It's
Mhm.
actually an endocrine tissue. It can produce hormones, cytokines, so pro-inflammatory chemicals, and an excess of the white fat tissue, also known as visceral fat, increases inflammation. It's in a chronic state of inflammation. And I think the best example, and that is more recent in our minds, is the COVID pandemic, right? So people with obesity were the ones having higher mortality or the ones that were sicker or more visits to the ICU. And it
Mhm.
was due to that chronic inflammatory state that the person with obesity was in. And I think that was a very um, palpable uh, view of being in a disease state for people with obesity. I remember in my practice, people were coming and telling me, I don't want to die from COVID. I need to lose weight. So I feel like people very quickly got the message versus when we used to say in 20 years, you can develop type 2 diabetes or complications if you don't lose weight now. But came a virus and it was something acute.
You mentioned COVID. Do you think COVID, because I could tell after COVID, this health conscious movement started. Now you have been practicing obesity medicine and endocrinology for many years. Have you seen a type of shift in your patient's mindset? Is this heightened awareness when it comes to health and obesity, or it's been always like that? We just more aware of it because of the social media and the internet?
No, I saw a completely shift, an
Mm,
incline on awareness of somebody's weight. My practice when I opened it six years ago, my private practice here in Manhattan, it was more of a like mix of endocrinology and weight loss. But during COVID, it made a completely shift, and I would say 95% of my patients now and coming in is for weight loss.
what do you think created that shift?
So one, the awareness that having obesity put you in an acute disease state or make you put you acutely at risk for other diseases to
Mm,
happen, right? That was one. So the demand of awareness was there and wanted to change it. And then it happened to be that we actually had the treatment for it for the first time.
mm.
Right. So it was the demand was there and the supply was there, or the means to improve this was there. And that was like the boom. I call it like the perfect storm is where we are right now.
So at what point would you say, I'm just curious, at what point did you actively make it your mission to treat obesity during this pandemic? I know 2020 it hit, and then we found out that obese patients and patients with multiple risk factor are obviously at heightened risk for mortality from COVID. At what point did you say, okay, I really have to take obesity even more serious than I had been, and really get out there and promote weight loss?
It was,
Do you remember that moment?
I remember it was not a single point in time. It was a period of time when I started having this influx of patients with obesity and me interviewing them in their appointment and talking to them, that I learned what I never learned in medical and endocrinology fellowship, or even as I was taking my obesity boards, is that patients, every single one of them, was telling me that they were eating better, that they were
Mm,
counting calories, that they were exercising, that they will tell me a list of diets through their life, following recommendations. They were aware, some had chefs, some had private trainers. They were
mm,
doing everything in their control to lose weight, and it was not happening.
mm,
So for me, it was such an eye opening to learn that patients were actually listening to us and following our recommendations, because before we used to think we give them this the recommendations: eat less, exercise more, and then the patient would come back and there was no weight loss, and the first thing we would assume is the patient didn't follow our recommendations, didn't do better, that if they wanted it they would have happened already. So we doubted patients, right? I mean, like, is he really listening to me when they tell you I really eat very small? We used to say, yeah, if I'm sure if I go to your house, I'm going to realize and see how much you're eating. That's our thinking as doctors, right?
yes, yes.
And it was very humbling
Mm,
for me to learn and I was very lucky to have the availability to have that time to really talk to patients, right? Because in a 15-minute appointment,
yeah,
in a 20-minute conversation, you're not going to dive deep. The patients won't open to you in such a vulnerable state,
yeah.
right?
They won't even trust you enough to
Yeah,
open up.
to
Yeah,
open up, like you're going to judge them, you're going to
yes.
misjudge them, right? So I had this great opportunity in my time that I designed my practice in a way that it was patient centric, not insurance centric, not quantity. I immediately said I want quality care. And through these conversations that I had through my patients, I learned all of this. And that is the moment that I said, okay, we've got it wrong. We've had it wrong all this time. It really is not working.
So it was not something you learned in medical school or in residency. It's something you learned from your patients once you spend enough time talking to them, where you realize there is more to it. It's not just you're lazy or you're this or that. Almost like shaming them.
Yeah.
It's a much deeper psychologic issue and physiologic issue.
And I learned that some patients, this has been their life for decades.
Mm,
Their life revolves around their weight, around that plate in front of them. Like, how
mm,
is that going to impact my weight? Am I going to feel guilty? What do I have to do later to reduce the calories that I consume? It's just like, it was like 24/7. And to me, it was very, I felt shame that I contribute as a
mm,
doctor to that thinking through my patients because I didn't have the knowledge,
mm.
right? And I asked, the first question that I ask a new patient is, at what age were you conscious about your weight, right? At what age was you conscious about your weight
That
or
there
your
is such a
eating?
thing that you have to pay
And
attention to.
7, 8, 9. My mom put me on a diet at 10.
Oh my
So
God.
it goes so far back, right?
So what's the solution? I mean, let's say you're a mom with two children and you see it's not going well. Like, how do you then not, I guess, traumatize or stigmatize things for your
That,
children?
I mean, that's a very
I mean, I guess for
hard.
one, the usual things that we do, just a healthy lifestyle and make sure they get used and develop habits of a healthy lifestyle, right? For
Yeah,
one.
but again, it's not lifestyle only that's going to prevent obesity, right?
That for children, I'm talking about for children.
For children too. So we know now that the parents' weight preconception can impact or predispose the weight of their children in their lifetime, right? There's
Hmm,
a
can you talk
lot
about
of
that?
data, a lot of papers, a lot of data showing of, so we have obesity, which could be monogenic and polygenic, right?
Hmm.
So monogenic is a single gene disease, and those type
Hmm.
of monogenic causes of obesity are very severe and really showed in very, very young age. At 2 years old, at 3 years old, children have
Hmm.
severe obesity, right? Now we have the polygenic when it's just not a single gene mutation, it's different genes, and that is where heritability comes into
Hmm.
play. Right. So if the father is overweight or has obesity preconception, or the mother, or in many cases both,
Hmm.
that can account to 50 to 70% hereditability on the children's weight,
Hmm.
right? So also it's found that hyperpalatable genes are also transmitted through the offspring, right?
Okay.
So we're learning more that goes even beyond preconception that can predispose somebody's weight. So you have, starting with that for children obesity, right? Or for children, they're already coming in with a high probability of struggling with their weight if their parents also did. Then we add to that food industry, right?
Mm-hmm.
The access to good food is very low. And even if you have the access, it's still difficult to get good, healthy, quality food. And then we go into environmental factors, living in areas that doesn't promote activity, right? Doesn't promote walking,
Yes.
sedentarism, and
Yes.
then food in schools, right? I mean, really, when
It's,
you ask a
don't get me
parent
started on that.
to take it into their own to control their kids' weight, it's almost like, I don't want to say mission impossible, but
Yeah.
we're set to failure, right? So you really have to go to extremes to avoid that. I'm not saying it's not possible. I'm just saying the environment that we live doesn't make it easy for us.
So I guess is that why most diets fail? Or I know you pointed out a lot of important and interesting points from genetics to environment to availability to education. Um, at which point then, or where does one start? Because this, anytime you bring in the word genetic, I feel people use it as an excuse. And it's very dangerous. It's a very slippery slope because I feel sometimes it's used as an excuse, although oftentimes, and I don't know the statistics on these obesity genes, how frequently they are as far as epidemiology, epidemiology, epidemiologically how frequent it is disseminated in a general population. Um, but at what point do you um, explain to the patient that it's, even though it could be genetics, that they have to take accountability and make some changes? How do you do that? This seems to me like such a complicated thing. And I guess if it was so easy, we wouldn't be talking about it right now. It wouldn't be the main topping point of our society. Where does one start? Like, let's say someone is obese and they might not even have access to you to come to your practice. What is recommendations that you can give these people?
So uh, the we can talk about currently what we can do with our giving situation of this obesity epidemic, right? And we can
Mm-hmm.
talk about what we can do in the next generations to prevent this. Um, and I start with a patient that comes to me and tells me wants to get pregnant, and
Mm-hmm.
right. Um, my biggest recommendation to avoid this being constantly passed to generations is that preconception, you start at a healthy weight, right? If you're thinking of having kids, of getting pregnant, my oh, I'm so sorry, that's my
No
kid.
worries.
I'm so sorry, so sorry.
No worries.
Um, hold on, I should mute this. She's not gonna stop. You know how this is my 9-year-old. Okay.
My phone's connected to my laptop too, and when it rings, my laptop rings.
Um, let me and my notifications, because my kids, if I don't pick up, it's like 10 times. Wow, it's off. I don't even know why. Okay, so preconception, the best advice is that you start in a healthy weight, because
Mm-hmm.
you're already cutting by half the chances of your next generation to struggle
Mm-hmm.
with their weight, right? Second is education, right? Educating yourself about food industry, about food choices, about what is the control that you can still have, right? I mean, eating a healthy diet, exercising,
Mm-hmm.
strength training, and then also the acknowledgement that we have medications, right? But when you talk about accountability, we go back to the same idea that we just began talking about it, right?
Mm-hmm.
A patient can have 100%
Yeah.
accountability and still not lose weight.
Yeah.
And what happens in those situations is that to have that accountability, that it influence their weight completely, is usually something very restrictive
Mm-hmm.
and not sustainable long term, right?
Yes.
Because again, lifestyle is not just the
Which is
only.
why most diets fail, in my opinion, because
Exactly.
most diets are restrictive, whether it's caloric, whether it is ingredients. They're so restrictive, and most people can't sustain them long term.
Yeah.
And so that's a very good point. But my question was, where does one draw the line between genetics, meaning factors that they can't influence, and factors that they can influence? How does one? Because to me, I've been treating patients for weight loss in the past 2 years now to prepare them for surgery. So for my patients, if they are obese and they want to have some cosmetic surgery, and that's how I got into obesity medicine. I felt like it's not safe for them to undergo a 6-hour anesthesia, so they have to lose weight. And the story was the same. Yeah, I've been trying for 6 years, and me then asking, well, how's it going? It's like, well, I actually gained 40 pounds. I'm like, you gained 40 pounds trying to lose weight. So that's how it got on my radar, where I said, obviously the primary cares aren't doing enough to help these patients, or whoever they're seeing, obviously they're not getting the information that they need. I need to educate myself so at least I can help them to guide them in the right direction. And when that happened, I went down the rabbit hole, and then the GLP-1s, I came across the GLP-1s, and the rest is history. But where does one draw the line between genetics, accountability, and accountability as far as changing their environment or looking deeper into their health, whether it is hormones, whether it is other methods or peptides or exercise, meaning help from the outside. Where does one draw the line as to what they need to be doing? Because I feel this is such a wild west out there, and people, especially with primary care physicians, becoming these gatekeepers due to just lack of knowledge and understanding, even contributing to the confusion of the population.
I, I'm a very proactive type of physician. So I would say I draw the line earlier than later,
Hmm.
right? And we can talk even about treating adolescents for obesity, right? That
Hmm.
early, that is where I draw the line is if we can spare somebody from those years of struggle.
Hmm.
And I would say when for somebody losing weight or maintaining weight becomes a full-time job, that's where the line needs to be drawn. And I would say, why let them get to that point,
It
right?
becomes counterproductive.
Exactly, it becomes counterproductive. It takes control of their life. It starts impacting mental health,
Mm.
right? And when we talk about causes of obesity, it's not genetics and lifestyle, right? We have hormonal changes, PCOS, perimenopause, menopause, hyperthyroidism, hypogonadism.
Hmm.
Then we go to aging, right? Aging is also promotes weight gain by decreasing your lean muscle mass, promoting or
Yeah.
increasing visceral fat. And then you go into environmental factors. The food industry, right, is everywhere. And industrialization of where we live, endocrine disrupting chemicals, such as I
Hmm.
talk about plastics,
Yes.
right? All of those they mimic our own hormones and promotes obesity, promotes disease. So it's not just genetics and lifestyle, right? It's multiple other issues and trauma, transgenerational trauma can also promote obesity. There's research on that, right?
Hmm.
So where we, and I don't want to make it feel like then we're set to failure, right? Because
Yeah, it
yes,
kind of sounds like it.
it sounds like that. I'm sorry, but eh, we have a solution currently, right? I think
Hmm.
for the next generations to not struggle as we struggle, different things have to take into place. Change in the food industry, right?
Mm.
We need something has to happen for the
Those
food
are long-term
industry.
solutions.
Those will be in the next 3 generations. That if it happens now, we'll see the results
Yeah, if
then.
if we start making changes now, we won't see the difference immediately. It will take
For
generations, you think?
generations for
Yeah.
us to see changes in our health if there's a change now.
Hmm.
Um, then you have of the things that you can control. You can control what you eat, how much you move, and also choosing or not choosing treatment. I like to say obesity is not a choice, but treating it, it is, right? And also, as a society, if we truly accepted obesity as a disease,
Hmm.
we wouldn't be questioning treatment or we wouldn't be looking at it as the last resource,
Sure. Well,
right?
we have a diagnosis for obesity. Obesity is a medical diagnosis. So by definition, if we have a medical diagnosis, or the reason why we have medical diagnosis, so that we can treat it, right?
Exactly.
So that has been already established,
Is it
right?
implemented though?
It
I
is
mean,
not, and then
it's
that's
not
my
implemented.
question. And why is it not implemented? And why are
Because
patients
as a
being
society,
shamed? Yeah.
yeah, because as a society, we see weight loss. And this is, we've been taught to
Hmm.
see weight loss as something external, right?
Yeah.
As looking good, as being attractive, as something
Hmm.
superficial,
Yes.
not as a health concern, right? But if you think about somebody with diabetes, you wouldn't question them being on treatment, right? Good for
Hmm.
you that you're treating your glucose because you were sick, you were not feeling great, and you can this lead to disease.
Yeah.
But for weight loss, if you as a person are thinking of weight loss as something superficial, it's going to seem bazooks for somebody to take a drug for weight loss.
That's where the shaming comes in.
That's where the shaman is. And that's
And
where they call it the skinny fat, the skinny injection, because
yeah.
you're thinking as an individual and you were taught that as in the society
Mhm.
and our culture, that skinny is superficial and that skinny is not necessarily health, it's cosmetic.
I have to be honest with you, Rocio. I'm so disappointed and I don't care if I get ripped on social media for saying this, but I mean, someone has to say it. I'm so disappointed at our medical community and our medical colleagues for not only gatekeeping these obesity drugs, peptides like GLP-1s that we're going to talk about, okay? Because we're going to talk about what they are and how they can help and other benefits that they have that we're finding out every single day. But also for shaming patients or telling them to do the things that me and you just talked about that they've been trying for decades and they have failed because it's more than just that. It's more than just exercise and diet. Um, because of lack of education and lack of knowledge and disseminating incorrect information and confusing the patients and omitting them from a potentially life-saving treatment. Because the reason why I'm saying that in our medical community, obesity is a diagnosis. Each diagnosis should have a treatment. And when we choose a treatment, let's say for cancer, we don't just pick a treatment out of our hat. There is protocols, there is guidelines there according to research, whether you do radiation therapy, whether you do chemotherapy, there is guidelines. You don't just pick random stuff based on what your opinion is. Yet for obesity, there is no specific, unless you're board certified or an obesity medicine physician or board certified in obesity medicine, you really don't know what you're doing. And yet is the number one metabolic disease in, at least in this country, or that's contributing to then the number two, three, four metabolic diseases in the country, which is diabetes, hypertension, all the other metabolic dysfunctions. So why is that? Why is it that they don't get better guidelines? They don't get the boards of their specialty boards aren't really reinforcing it enough. Like, what is going on? Like, why is it that influencers have a louder voice than actual physicians? It's so bizarre to me.
I'm going to tell you why. And you
Sorry, I
are
just had to go on a rant, but
it's fine. And you are a surgeon and you do plastic surgery, right? So
mhm,
you don't deal with health insurance.
yes,
Uh, the other
correct.
side of those primary care family practitioners, usually the first doctor that a patient can go, I would say 70-80% work with insurance or
Hmm.
in an institution, right? They it's the healthcare system that doesn't is how the healthcare system is set up is not useful, is not helpful for patients, it's not helpful for doctors. You have a doctor, right, a primary care that sees 30-40 patients a day, uh, that gets 15 minutes with each patient. What are they going to do in those 15 minutes? And if they're primary care, they're dealing with their hypertension, type 2 diabetes, high cholesterol, and whatever else is happening in a patient. In those 15 minutes, they're never going to have the opportunity to talk and learn from patients, as I the example that I gave of myself,
Yes.
right? Is health insurance really controls the time and how a doctor practices. And I can tell you, because I was in that spot many years ago and I hated it. And I said, I can do so much more for my patients if I had the time. And that's the reason I went into private practice. And that's the reason I don't take insurance, right? And the reason that I've learned all this knowledge and that I'm here talking to you is because I took that leap of faith on myself
Hmm.
to work off network, out of network.
Granted, so I would then say, well, they're victims of the system, right? I get it. But why do I hear, not once, multiple times, patients come to me, they ask me for GLP-1s, and I'm thinking like, this is this shouldn't be my job. I don't know how I got into this, but this shouldn't be my job. And then when I ask them, well, did you discuss it with your primary care doctor? They say, my primary care doctor won't give it to me. So now the first thought is, okay, maybe their insurance doesn't cover it or this and that. And then I dig deeper. I say, well, why does your primary care doctor not give it to you? Said, I don't know. My insurance, I actually checked with my insurance and it's even covered. I'm like, okay. And then they go, my doctor says it's not good. It causes thyroid cancer. It causes. So basically, they tell me all the things that this fear mongering in the media you hear, or these influencers on social media do this fear mongerings for likes or follows. But even you hear it on mainstream media, the stuff, reporters talking about it, and you're thinking, wait a second, that's incorrect. This is just simply not correct. But when physicians tell it to their patients, that's where I draw the line.
So
Why is that? Is there an
we
excuse for that?
um yes and no. We doctors, we don't prescribe what we don't feel comfortable with,
Hmm.
right? Because you don't want to deal with side effects. You don't want to create this more symptoms on the patient or make it worse for the patient. So we don't prescribe what we don't know, or we don't prescribe what we don't have experience with. So most likely this whatever doctor is not promoting or prescribing this type of medication, GLP-1s, is because they don't know how they work. They don't really know the side effects. They don't have enough expertise
Yeah,
putting patients on it and having and seeing them come with results or side effects and how
yeah,
to manage them, right? Number one. Second, I would say better off that they don't prescribe it if they don't know how they work, because
fair,
then they'll create more side effects and bad headlines of this
fair.
wonderful type of medications. But then we go to the accountability part, right? That you don't know doesn't mean that somebody else doesn't know. So then you
Thank
need to
you.
refer and be honest and say, I don't have enough experience with this medication. I'm going to refer you
Mm,
to an endocrinologist, or I'm going
yes,
to refer you to an obesity board certified physician, right? That's where we'll add the fault on the physician, right? That they don't say, okay, I cannot prescribe it, but what is the option? What are
mhm.
you offering me? Refer me to somebody else who knows, guide me to where to go, right? So that's where the accountability should be
Well,
happening.
I'll be honest with you. I think many physicians, just like me and you, they're normal human beings. They let their own personal opinion about stuff cloud their judgment. And I think a lot of times, and that's my feeling from talking to my patients, that's why they're not referring out to an obesity medicine specialist, endocrinologist, or someone that is experienced in those medication. I think oftentimes, which to me, it's not ethical to let your opinion, your personal opinion, which is completely emotional, guide your judgment and misinform the patient. I see a lot of that going on, and I hope that that will stop. Thankfully, patients are getting so smart because they have access to information, they have access to these podcasts. And with voices like yours increasing, they will have a higher chance and higher likelihood of hearing another side from an expert and then questioning what their doctor might have told them based on their personal opinion. Um, so I think that's where social media is a good thing. People always demonize social media. I think social media is both good and bad. It's like your kitchen knife. You can cook food and live healthy with it, or you can murder someone and rob a bank with it. So, um, but that's a different topic. Now, um, is are GLP-1s, these weight loss drugs like Ozempic, Wegovy, or tirzepatides, is that then cheating really? Because a lot of people say that's cheating. A lot of people shame patients that are on them. At which point, do you first of all agree with them?
No, of course not. But before we go into that, I want to say also talking about doctors, and like you said, I'm going to say it. I have to say it. Somebody has to say it. Is how many of us doctors are in a healthy weight?
Mm,
Hmm?
you really want to go there?
Well, if we're talking about why we're not having, or why doctors are not having the conversation, then it is really if you took into account what you're recommending a patient to, then you will be proof of that, right? Um,
100%.
but doctors, we're humans, right? We struggle too.
Sure.
So, but that's where you say your own personal experience or bias is interfering in the care of somebody else. So that's the psychology behind it. But okay,
I'll
I
throw,
just said,
okay. So since you went there, I'll throw you another good one. I don't know where we're going with this conversation now, but it's just happening. What do you think if you would compare the prescription of um, antidepressant compared to the prescriptions prescribed for weight loss? Which one is being prescribed more, in your opinion,
of
today?
course, psych medications, antidepressants, anti-anxiety medications. Um,
Do you think where mankind has gone that crazy that psych medicine are some of the first, I think it's the second most often prescribed drug?
I mean, I do
And
feel
how much of it do you think we can treat with the things that you talked about, um, with the pressures of lifestyle improvement, where it feels like people are hitting a wall and the wall is so tall that they can't climb it and they constantly be told, well, you need to climb it no matter what. How much of that do you think is contributing to the need for antidepressants?
I mean, I think we know all the metabolic complications of obesity, right?
Hmm.
We built specialties on it. I don't think we know enough or talk enough about the mental health complications from obesity,
Right.
right? If you're
Oh.
talking about a 10-year-old that it's already put on a diet telling them that their body is not the right one, that leads to anxiety, depression, suicidal thoughts, right? Um, so that's, I think that's one big part of our mental health situation, and I think that's one big part that I see improvement with GLP-1s is that peace of mind. And patients say, for the first time I feel control, for the first time I feel relief. um, and also, when you explain to a patient that is not their fault, that they were not causing 100% their obesity, I can even see it in their shoulders when I have that conversation. They relax,
Mm,
right? It's just almost a physical change when you explain to them
mm.
that, hey, if your parents had obesity before they had you, that it's already putting you on a bad spot, right? Um, and you know what's interesting about weight loss medications is that for the majority of patients, I would say all of them, I don't want to generalize, but for the majority of patients, if they have the right guidance, the healthy lifestyle choices come after there's some
Mm.
weight loss or once they're on that weight loss medication. It's
Oh, see,
incredible to see.
yeah.
And when you talk about shaming on this medication, no, because this is not a self-induced disease.
Mm.
We wouldn't shame somebody who goes on diabetes medication or on a diuretic for blood pressure. We
I'll,
wouldn't even think it twice.
I haven't. I'm so glad you said that, Rocio. I have this amazing story. I'm currently writing a book, and that story is in
Me
my
too.
book. Yes, you too. Oh my God.
Yeah, I'm writing a book. It's
All right.
coming December.
So I'm gonna have to. All right. So I'm gonna send you a manuscript. I want you to read it, and I want you to give me your opinion and feedback on it, and I'll be glad to do the same, because it's. I want people that know so much more about me, about this topic, to give me insight than just some random reader. And this is so important for me. For me, this is going to be the second half of my career. I'm so dialed in, so passionate about this because I think we can help so many people. But let
Yes.
me tell you the story of my patient Jose. He came to me a year ago, um, young patient in his 30s, for liposuction of the chin and neck, and he just wanted a chisel jaw, which is, after COVID, this was the number one procedure people came to me for. And that's how I became aware of this thing called obesity. People coming for liposuction. And really handsome guy, tall. He was 6'4". He had beautiful facial anatomy from the bone structures and everything, because that really plays a role in how your soft tissues drape over your facial bones. If you have smaller bones, everything sags and it looks more heavy. And if you have more defined structures, so he had very defined structure. And I looked, he was about 60 pounds overweight. And as he's talking to me, telling me about what he's looking for, what his goals are, I couldn't help it but constantly think that this young man shouldn't be overweight. Why is he overweight? What is going on? And I had this internal uh, dialogue going on in my head while he was talking. And then I said, I need to bring this up. It's always, I don't know, you're so much probably better than that because you do that for a living, talking about weight loss to your patient. But for me, I always am very self-conscious so that I'm very sensible, so I don't offend them, and I don't want to bring it up before they have trusted me and opened up. Yeah, I feel even though as a doctor, it's our job to do that, but I always try to approach it in a sensitive way because I know they're probably insecure about it. Um, and he had this desperation in his voice that I said, you know what, I'm just going to ask him. And I said, well, you can pay me a lot of money for me to do this, but I can't help it to think that at your age, losing weight is you're going to benefit more from it. It's going to be more life changing than you paying me thousands of dollars to do liposuction. And I feel like I really should have had a different conversation with you. So I'm just going to say it. And then he immediately stopped talking and looked at me, and it goes like, I've been trying to lose weight. I just don't know how. I've been trying everything. And then his eyes got teary. I felt this helplessness. And it was almost like he was so happy that I brought it up. And I said, look, I could help you, but you need to change a lot of things. Also, one thing at a time. So I spent about 40 minutes with him, 40 minutes of time with him to see what his lifestyle is like. So what I noticed is that he's basically sitting in front of a computer. He has a very sedentary lifestyle, sitting in front of the computer. He was a computer analyst, a government contractor, and sitting in front of the computer all day long, eating potato chips. And so I said, well, that's easy because that is just some minor modification. So I gave him some tips and I said, if you promise me to do that, I will put you on GLP-1s and then we'll see each other once a month. And and then at 4 months, we're gonna see where you are and then can still make a decision. And I didn't want to take him the liposuction away from me because he was really adamant. I said, I will do it, but give me 4 months. I will do it in 4 months. I promise you, if you still need it. He said, fair. We literally shook hands, and I always make this joke. I'm like, handshakes or pinky promise. And then he left, so we put him on GLP-1s, and my nurses followed him up, etc. And I saw him after 4 months. He came, sat in a chair. I didn't recognize him, so I didn't even know who he was. So that's how much he had changed. And I introduced myself like I'm seeing a patient for the first time, and he looks at me, he looks at my nurse, kind of like, is he joking? And I look at everybody, was this weird mood in the room. I said, what's going on? And it's like, well, you know me. I'm Jose. And I'm like, Jose? And I had to look at the chart, and I had to literally read my previous notes. All of a sudden, it hit me. The way he looked like a supermodel. Handsome, confident. I swear, I did not recognize him. And I had to sit down. I was like, oh my God. And he see that reaction on my face, and he started laughing. And then right after he started laughing, he started crying. And he goes like, you changed my life. I quit my job. When I went home, the next day I quit my job because of you. I'm like, oh, that's not good. Like, why'd you quit your job? He's like, I'm going to school for nutrition and I'm becoming a personal trainer, and this is what I'm going to do for life. I changed completely I want to change my profession. I can't believe that within one conversation you changed my life so much, and I want to help other people change their lives too. So he literally quit his job. He went to nutrition school. He is becoming a fitness instructor, and because he realized how important the importance of lifestyle modifications are, which he had done leaving my office in addition to the GLP-1s. So when you said they can motivate you, the GLP-1s can motivate you to change your life, the question is it the chicken or the egg? Does weight loss promote health or health promote weight loss? Which one is it? Well, in this case, it was weight loss promoted health, not the other way around, which is what we were taught the other way around.
Yeah,
So I
exactly.
want you to talk about your experiences in that and the importance of this so people stop shaming these drugs and realize how we can change people's lives with these. I don't like to call them drugs. They're really peptides,
Well, they're hormones.
hormones. Yes.
I mean, first is to have empathy, number one, right? It's like you have to understand that when you see somebody with obesity, number one, they know they have obesity. Number two, they don't want to have obesity,
Mm-hmm.
right? Um, and number three, believe that they're trying, believe that they're modifying, believe that they're listening,
Mm-hmm.
and understand that it's a health problem. It's not a willpower problem. It's not a cosmetic problem. It's a disease, and there's treatment for it, and it should be widely accepted, and not let your own bias of what weight is or
Mm-hmm.
what has worked for you or not worked for you shame other people from doing it, right? And also, like, respect when people are on a GLP-1, and don't push food to them, right? And don't say, oh, that's all you're gonna eat, or stop saying, oh, stop losing weight, you look sick. That's none of your business, right?
Mm-hmm.
Or I mean, believe me, we're trying to get to a health goal, not for somebody to look good enough for you, or
Mm-hmm.
that's enough of weight loss for you, for you feeling comfortable, right? I
Mm-hmm.
think that's another one. And educate yourself about it.
Yeah.
And like it happened to you, like it happened to me, once you know, once you understand, and once the blindfold is taken away from you, your responsibility is to share that knowledge
Mm-hmm.
and to correct when somebody says something negative or ignorant about somebody with obesity. Oh, they would have done it if they wanted it. It's just educate other people, right? I think the
Mm-hmm.
more we educate people, the easier it will become, and it will be more accepted.
I love the way you put it, and I think especially in certain cultures, this is more extreme. I know I come from a Persian culture, and um, if you look, if you have a perfect body composition, to your mom, you're underweight.
Yeah.
Like your mom
Same in the
come, yeah,
community.
it's like, what's going on? Like, you look so sick. Like, why do you have no meat on your bones and you eat this? And it's a cultural thing. So, and for culture, I don't know how long it won't change in decades. It will take centuries. But let's talk about who is a real candidate for GLP-1s. But before we talk about that, I just realized that we haven't even told the audience what GLP-1s is. They've been hearing it for the past 45 minutes, and we haven't. I know, I mean, by now you would think people know, but just for the sake of a definition, how do they really work? Very briefly, in maybe one or two sentences, how do they really work? And then who is the ideal candidate and who should not be taking these medications?
So GLP-1 is a hormone that we make in our gut,
Hmm.
in the small intestine, and it's secreted or produced when our glucose raise up in our bloodstream, right?
Meaning
When
after we eat, for
after we
example.
eat, yeah, after we eat, this hormone is produced in our intestine. But there's an enzyme, the DPP4 enzyme, that breaks it down within 2 to 4 minutes, right?
Hmm.
So it's produced, but it has a very short-lived effect. GLP-1 analogs, what we know as Ozempic, Wegovy,
Hmm.
Mounjaro, the commercial, the synthetic version of it, is a long-acting form that is not broken down by this enzyme. reason that it has a longer life, right? Like
Mm-hmm.
even a week, some like
Mm-hmm.
semaglutide, tirzepatide. And the way that they work for weight loss, I like to say that it targets the two reasons that humans eat. We eat for survival, for energy, and then we eat for our reward.
Mm-hmm.
For the survival part, what it does, it increases your satiety hormones when you start eating. So you get
Mm-hmm.
fuller with half of what you normally would have
Mm-hmm.
need to get full. And then in between meals, it suppresses ghrelin, your hunger hormones, right?
Mm-hmm.
So you eat smaller m- through more content periods of time in the day.
Mm-hmm.
That's the gut level, which is almost similar to bariatric surgery, right?
Mm-hmm.
But then we have receptors for this hormone in our brain in the amygdala, where the hedonistic eating and drinking area is, where we eat for an anticipation of our reward or drink for anticipation of our reward. This hormone blocks those responses. So the behavior at the beginning, when you start on this medication, if the behavior is there, you reach for it, but there's a blunted effect. You don't feel, you don't get the reward anymore for whatever anxiety, depression, boredom,
Mm-hmm.
snacking, whatever you were getting, anticipating that reward, it stops it. So you don't think about it. You get hungry, you enjoy your food, but then you get full with smaller portions through longer
Mm-hmm.
periods of the day. So that's how they work.
Wow, this was the best, most concise and shortest explanation ever that I've heard. I'm gonna have to memorize it verbatim. For those of you, you mentioned the word amygdala. This is for the audience that is not the medical community, is the center in your brain that is in your limbic system responsible for emotions, flight or fight, is called the fear center, and that's what
Pleasure.
that pressure, that's what kind of drives also habits or of eating, and so the GLP-1s also affect that part, and so that's the dual function we were talking about. So now, who is a candidate and who shouldn't be taking it? Let's say, let me throw you this one. Um, uh, Dr. Whalen, I'm struggling to lose these last 15 pounds, and I really want to get on these GLP-1s. I've tried everything. I'm going to the gym. I just can't lose 15 pounds. If I lose another 15 pounds, I'll be happy. I don't have any medical problems. I don't have diabetes. I don't have any metabolic disorders. I just need to get into these jeans that I used to wear when I was 25, and I just need another 15 pounds.
I will put her or him in a
If
body
if
composition.
not, I will go crazy and I'll be depressed, and I'll throw you this one too.
So usually because I do body compositions on every single patient. You walk through my door, you get a body composition basically. So if I have most of the times that I have patients that's like that, oh, I only have 10 pounds to lose. I only have, usually it turns out to be 20 or 30, right? Once we put somebody on a body composition, the truth shows, right?
Okay, let's
It,
talk about body composition then
yeah.
also.
Who's a candidate, right? So if we go by BMI, then 27 and above with one comorbidity meets criteria for weight loss medication, or BMI equal or greater than 30 without a comorbidity meets criteria. But if you go to that's a very outdated tool that I
Mhm.
don't
Yeah,
I
I mean,
don't
if you're like a bodybuilder, you have a lot of muscles, you have a lot of your
Yeah,
BMIs.
that's not I mean, that's the old thinking, because we rarely see that. I
Gotcha.
mean, unless you're doing body compositions on WrestleMania or something like that, right? But the regular people, it's actually
Yeah,
the opposite. You
yeah.
see normal BMI
Mm-hmm.
with high percentage body fat, high visceral fat, and low muscle mass. So
Gotcha.
when you average it out, oh, it looks like a BMI of 21, and no,
So,
you're under muscle and overly fat,
so
and you
how
have
do you know that you're under muscled and over fatted, I guess. Is that the word?
definitely about, I mean, I think
How would you
with
know if you're under muscled?
with sophisticated medications, we need to do sophisticated tools, right?
Fair.
There's no, so I think anybody who's jumping in this wagon of prescribing GLP-1 medication should do it responsibly with body compositions, right? Because at the end of the day, you don't know what the patient lost. Could have lost 10 pounds of
Mm-hmm.
muscle and 10 of fat, right? And you made him even worse metabolically unhealthy. Uh,
100%.
so definitely you need a body composition. So for that person that has 15 pounds of weight loss to lose, first I would do a body composition. Second, if it feels like a full-time job trying to lose those extra 15 pounds, and you need it, and you need to lose those extra 15 pounds, you definitely will benefit from a GLP-1 medication. I mean,
Well,
what
for
else can you ask for the patient,
for
right?
those of you who are rolling their eyes and saying, "Oh God, please, just stop eating potato chips or go to the gym for 15 pounds, for God's sake, do you really have to?" Can you please explain to them why? Because you said something important. I think it got lost. Can you explain to them why you consider them a candidate and why it is important? Because it is consuming their lives and
Yeah,
affecting them in a
because
negative way. Can you kind of dive a little bit into it? Explain it for the biggest doubters out there.
because if it was as easy as just eating less, they would have lost it already,
Hmm.
right? I mean, we cannot assume that somebody who has 15 pounds and hasn't lost them are ignorant. They
Hmm.
don't know what they're talking about. They don't know how to count calories. They haven't read a diet book,
Hmm.
right? Uh, that's another thing
So
that I
there's more
think we
to
should
it.
say.
Yeah.
Because you don't struggle with weight, or because maybe you do lose weight if you restrict yourself, doesn't make you better or more
Yeah.
intelligent than somebody who's trying and it's not happening, right?
Hundred percent.
I think that's one thing that we have to stop. Don't assume that the person doesn't know what they're doing, hasn't tried, or is not currently trying. But so if they need to lose that amount of weight or more, or 10 pounds, but it's a full-time job in their life, they require weight
Hmm.
loss medication. Otherwise, if they didn't require the weight loss medication, they would have lost it already.
Hmm.
Meaning that there's so many other things in their environment, in their age, hormonally, that is not allowing them to reach that goal.
Yeah, and I think the psychological impact is totally underestimated. It's so funny that we're so quick to prescribe antidepressants, so quick. Um, like I'll tell you a story as an endocrinologist. You will be shocked. I went with my wife to the doctor. She was a new doctor that she went to. Her insurance changed, and she was going to pick up her thyroid medication, have them refilled or have them re-prescribed. And the doctor asked her about their symptoms. She's like, "Yeah, I'm kind of like tired and this and that." And she was back then in her early 30s. And the doctor said, "Yeah, I think this sounds like depression. I'm going to prescribe you antidepressant." And I was sitting in the room. I was sitting in the room. The doctor didn't know that I'm a doctor, so I didn't say. I usually don't like to say anything. I just sit there. I don't like to interfere. I have them do their job. And I thought I heard it wrong. I said, and then I saw my wife looks at me with a question in her eyes, like, and she's like, "I'm not depressed. I'm actually very happy. I just need my thyroid medicine. I have Hashimoto's and I'm hypothyroid and my levels show. I mean, did you look at my labs?" And the doctor says, "Yes, I know, but your symptoms are very suspicious for depression." And my wife, she lost it, and I had to calm her down. And I'm like, "Calm down, just it's okay." She's like, "Well, what is going on here?" And long story short, the reason why I'm mentioning it, this is not just one event. This is an event where I was involved. There are events of patients telling me, or they're on antidepressant, and I ask them why an antidepressant, and then I'm not a psychologist, so I'm not qualified to even diagnose or question a diagnosis. In my wife's case, I knew I was able to because I would live with her. But the psychological impact is not often talked about, and I see it a lot on my patients. They completely, in case of Jose and in case of other patients, just like him, it has such an underrated psychological impact, which then has this trickle down effect. I mean, when you look at how depression can affect your other metabolic function of your other organs, from your fat composition, um, all kinds of trickle down effect. When someone has 15 pounds or 20 pounds overweight and they've tried everything desperately and they just can't do it, they've been on every diet under the sun. They go to the gym 7 days a week, which I don't even go to the gym 7 days a week. I have usually one or two off days, and I'm a gymaholic. Um, and they want to lose, give them the 15 pounds for the love of God, you know, if because then there'll be happier people and then they can go on with their lives. And so the indications, they're much broader than the definition of obesity, in my opinion. Now, I know insurance companies have the reasons for that. That's great, but I don't think we should necessarily have insurances guide our treatment objectives.
And also, I think for what I see a lot clinically, a lot of the people that saying it's 10 or 15 pounds that I cannot lose and I'm doing more or I'm doing exactly what I was doing is usually people that didn't struggle with obesity growing up, right?
Mm,
It's people that were in a healthy weight
mm,
most of their life and now they're in perimenopause, now they're in menopause, or now they had a kid and they cannot get the weight back. So usually it's people that lived a healthy, but at the time that it happens, their environment, their hormones, their age is not helping them as they did before, right? Because if you have
mm.
somebody with severe obesity that had 80 pounds overweight and 90 pounds overweight, 60,
Yes,
those 10 pounds doesn't make such an importance, right?
good
But
point.
usually it's people that were always in a healthy weight and then something shifted
Hmm.
and now they cannot get back to what they know their healthy weight is.
So you mentioned hormones and perimenopause. I know it's a whole different topic, which I covered with Dr. Mary Claire Haver in my last podcast, but I want to bring this up, especially since you're an endocrinologist. How do you balance the prescription of GLP-1s and adjustment of hormone therapy? Do you do them at the same time? Do you do one first and then the other? What's your approach? And how do you see the contributor of the weight issue? Do you see it more in the hormone side, or do you see it in a more genetic lifestyle side, or is it just a combination of all of it?
I mean, everything in medicine is very individual, right?
Hmm.
It's depending on the patient, but it will be what are the most pressing symptoms,
Hmm.
right? Let's say they have obesity or they are overweight, but they're also in their mid 40s and they're not
Hmm.
sleeping,
Hmm.
right? Because of perimenopause, then that's a person that I may want to start both
Hmm.
medications at the same time. But let's say I have somebody in their early 40s and they're saying their weight gain is morely due to perimenopause, but they're not fully symptomatic. They're not having
Hmm.
the hot flashes, the night sweats, the trouble sleeping. Then I may start with weight loss medication and then
Hmm.
see what improves, right? Even sex drive, many patients
Hmm.
with low sex drive can improve with weight loss,
Hmm.
right? Uh, but
Can you explain that? That's interesting.
yeah, because self-confidence, right? I
Mm.
think for many patients,
More of a psychological impact.
more of a psychological impact. They don't feel comfortable with their
Hmm.
body, so that can suppress their sex drive just because of that
Mm.
poor self-confidence. That for many patients, once they lose the weight, that improves.
Mm.
But let's say somebody who's fully menopausal and they can lose weight, but their hormones are below zero, then definitely adding hormones will help them, right? Also, there's some patients that are very sensitive to medications, and if a patient like that, you don't want to put three new drugs on a patient, right?
Mm.
Because she won't like how she feels and she may drop treatment completely. So for those patients, again, what's more pressing? Is it the night sweats, the trouble sleeping? Then I'll start with hormone replacement therapy. And then in their next visit in 6 or 8 weeks, then we can start a GLP-1 or
Interesting.
vice versa, right? So
Okay.
again, it's very dependent on their current symptoms, weight, age,
I could,
preference.
gosh, I could tell you one thing from what I just heard from you. I wonder how many marriages and relationships these things can save. Thinking of how many relationships um, get disrupted, how many, and I talked to Mary Claire about this, the percentage of relationships that break up because of, all of these issues. That's to me another contribution of these drugs to our society, in addition to the medical aspects of it. But um,
What I
he-
see with GLP-1s, I see divorces happening more than saving
well,
marriages.
yeah, I mean that, but there has to be another
Yeah,
thing going
I
on
mean,
prior to that.
there was
Yes,
something
yes,
underlying,
yes.
right?
That
Underlying
that's
that,
just exposing something that was
yeah,
there.
that's exactly, that's exposing something
Yeah.
that's going to happen eventually.
Yes,
And
but I'm just going to talk. I meant relationships and
capacitive,
marriages. Yes, yeah, marriages and relationships that broke up because um, maybe there was lack of self-confidence, lack of sex drives, just mood swings
Yeah,
because of everything is just too much, and in addition, the hormonal fluctuations in perimenopause that are not being addressed, which is still baffles my mind that 25 years after the study came out that still physicians out there are not well informed, which is a whole different topic that we already covered.
that's
Uh,
another gatekeeping because
yes, another gatekeeping.
only
Yes.
4% of women,
Yeah.
or 4 to 6% of women, 4 to 6% of women in the US are on hormone replacement therapy.
What?
Even with all the
You mean
information that, right?
4 to 6% of perimenopausal women or all total women of all ages?
Total women of all ages
Okay.
that are only 4 to 6% are taking hormone replacement therapy.
And if you think about how many percentage of the total women are
50%?
candidates are 50%, right? Holy shit. Oh my God.
I mean,
That
50%.
low?
I mean, it's, yeah.
Wow. I would have guessed like by now at least
No.
half of them.
And that's another one that, I mean, and you had that conversation with the wonderful Dr. Marie Claire Haver, but that's another that I see as an endocrinologist is like, have you ever been talking about hormone replacement therapy? No. They told me no, it causes cancer. That's another one that is lacking a lot of information in the medical community of the benefits of it, and that it doesn't increase breast cancer, right? I think.
Yeah, it's well, I don't even know enough doctors in my area in the Washington D.C. area that I can refer my patients to. I know two or three physicians that I know. So if you know any endocrinologists in the DMV area here in D.C., please let
Well,
me know.
Dr. Rachel Rubin, she's not an endocrinologist, she's an
Oh,
urologist, but she
yes.
prescribes hormone replacement therapy.
I
She's
just
great.
had a patient last week. She gave me that name, Rachel Rubin.
She's
Yes.
amazing. She's
Good.
there in DC.
Perfect. Perfect. So next question. Um, why are these drugs so expensive? I don't want to create a political conversation, but very briefly, in maybe one or two sentences, why are they just so expensive and why can people get them in other countries so cheaply? Is it just simply price gouging here in the US or does it have other complicated reasons?
I mean, I think they're so expensive and they charge so much for it here in the United States because they can.
So, okay, so it's price gouging.
I mean, it's because they can. Um, but also, I think that the pen itself is an expensive mechanism to deliver the medication, right?
Hmm.
If in other countries, like in Mexico, Monjaro is now available, but it came only in vials,
Hmm.
so just the substance in syringes. So
Hmm.
that cuts the price significantly,
Sure.
right? In Europe, they have a single pen for a month of Monjaro, so you're only using one pen versus four pens, also, right?
Why don't we have it here? Why don't we have a single pen
You
here?
know, when the pens of Monjaro came out, when Monjaro came out, I spoke with the general
Uh-huh.
manager of Eli Lilly. I actually called him and I said, I am fixing something, obesity, but I'm worsening our environment. They're not
Sure.
recyclable. They cannot be burned. They go to landfill.
Mm,
So it's like imagine a pen per week per patient, millions of people using these pens. Plus, it increases the price, it increases the production. They have to build new factories just to produce the pen. So I think the pen itself is an expensive process and expensive to make. Um, but that's not the only reason because Wegovy, let's say in Europe, it's also a third of what is here for the same amount of pens, right? So
hmm.
I think it is the pen, but I think also it's because they can here in the United States. They can get away with it.
Interesting. So, what is the issue with just giving vials? And yeah, I guess logistically it will be a little more difficult because you have to educate the patient, handling syringes, etc., or having to come to the office once a week to just get an injection. But how do we do it with insulin? That's how we do. I mean, they inject themselves with syringes. They don't
Yeah,
have necessarily pre-filled.
I think we're gonna move into that. I think it's gonna take some patient adaptation to that idea of having to inject themselves with a substance. I think with the
Hmm.
pen makes it
But
Makes
how do diabetics do with insulin?
Well, also it comes in pens,
Mm-hmm.
right? I mean, rarely we use a vial and syringe. I
Yeah.
mean, we haven't used that in I don't know how many decades because even insulin comes in pens, right?
Mm-hmm.
So it's just we can learn, we can
Yeah.
re-educate ourselves, right? And
Yeah.
if the cost goes from 1,200 to 300, believe me, many patients say, yes, I will learn how to do it, right?
Yeah. 100%.
Occasionally, I have a patient that says, I cannot deal with seeing the needle. I'll rather do the pen.
Hmm. Interesting. So we talked about in the very beginning of the podcast about hormone disruptors. You mentioned hormone disruptors. Um, there is this, it's almost like a buzzword that's going on with all these influencers on social media. Everything is a hormone disruptor. Can you kind of like, as a endocrinologist who is an expert in hormones and hormone disruptors and endocrinology, tell us what are hormone disruptors? How do they affect our body, our metabolism, and where is it in currently today in our environment? What are the typical things? I'm not talking about this one thing in one part of the world. Like
Yeah.
everyday American in their daily lives, what they should look out for, what they should avoid, just at least tomorrow they can, or even today after listening to the podcast, start living a healthier life without having their hormones disrupted.
So endocrine disrupting chemicals are a real thing. They're completely real and they completely can affect negatively our health.
So
And
it's
when
not
I
fear mongering.
oh no.
Okay.
And when I talk about environmental causes of obesity, we can talk about it's endocrine disrupting chemicals promoting obesity, right? Endocrine disrupting chemicals, they are substances or chemicals that mimic our own hormones. So they go into the receptors that our own hormones would normally go and don't allow them to do their proper function, right?
So
So
they're blocking the receptors.
blocking the receptor of our natural hormone by mimicking our own
Mm.
hormones,
Which
right?
hormones are those in specific?
Estrogen.
Mhm.
Estrogen is one of them, and cortisol, testosterone. There are many type of hormones. They can cause infertility. We can see infertility from endocrine disrupting chemicals. Um, I just yesterday there was a very interesting article published in Biomedicine that it was a large study that started here at NYU. They looked at 370,000 deaths due to phthalates, which is plastic. So worldwide, 13% of cardiovascular disease deaths are caused by, in 2018, just in 2018, they were caused by endocrine disrupting chemicals, specifically for phthalates that are found in plastic.
What is the number one source of phthalate in our today in our
Plastic.
environment? Like
Plastic.
like bottled water?
So
Would that?
food packaging can be on it, food
But
containers.
everything is packed into in plastic today. Like
Well,
like
and that's why we are have the problem that we have, right? That endocrine disrupting chemicals promote metabolic disease, right? They promote inflammation. They put our cells in oxidative stress,
Mhm.
and it's found in plastics, pesticides, painting in our walls, fabric, vinyl. I mean, cleaners, cosmetics, right? I mean, the list goes on and on. We cannot, I always tell my patients, unless you go and live in a farm in the middle of Norway where there's nothing around, then that's the best way to avoid it. But we live in an industrialized world. But there's some things that you can control starting in your home.
So let's talk
First of
about
all,
that. Yeah.
yeah, get rid of plastic containers.
Okay. I've done that.
Move,
Check.
move to all glass containers, right? Get rid of all plastic bottled waters.
Done.
Do glass or stainless steel. Never, ever. This is like the if one thing you can do is never heat in the microwave anything in plastic because the heat makes the BPAs, the phthalates spill into your
Hmm.
food or into your water,
Good.
right? Whenever I walk here in New York and like I pass through a pharmacy outside and in the window you have the boxes of bottled water, plastic bottled water
Oh,
and the sun hitting it, I'm like, oh my God, I'm just like,
I
so
know. I
never
can't
heat
escape it
anything.
anymore.
Yeah.
either. It's
So that, and then also like choose chemical-free cleaning supplies, right?
mhm,
That we have everything, even
mhm,
less BOCs, which are chemicals in your paint because then you're inhaling them, right? Fabrics, those like repellent, they are very high in chemicals and pest and things, heavy chemicals that are going to be endocrine disrupting
mhm.
chemicals, right? So there's little things that we can do in the day to day
That have a
that
great
can,
impact. Yeah.
yeah, that can impact our health, right? I
At
mean,
least the things you can control. I mean, there's things that we can't control because, as you said, we live in a society that it's just the way it is. But you can start at your own home.
yeah, you can start in your own home, and even when you do grocery shopping,
Yeah.
right? Like
I don't think
avoiding
I agree with you on bottled water. I mean, you never know where that bottle was. It was sitting
we're
in the
sitting
sun
for
before.
hours.
Yeah. So every time I see someone drinking out of a plastic bottle, I really cringe and I have to hold back to tell them, no, don't do it, you know?
Yeah.
So,
There's pitchers of water too that are glass for filtering water, and the filter it comes in stainless steel. So I mean it's an investment, but then
yeah.
you're filtering the water in a glass container with zero plastic, then you put it in a stainless steel bottle or a glass water bottle, and then you are really avoiding there, and that makes that it is impactful. I
Yeah.
mean, I don't know why this article that it was so well done and it showed such a high percentage of cardiometabolic death. It's not a
Hmm.
headline, right? Because
Yeah.
it's not sexy. But whenever we're talking or people say, "Oh, why are you just prescribing medication? What are we doing about the food industry?" Then this is proof. These are things that you think are minimal can impact really and prevent disease.
Yeah. Well, I think the reason is because right now we don't have a replacement for all this. We don't have a replacement for plastic.
Well, cardboard, a lot. There's cardboard. There's other things
No, as
that
far as mass production, as far as scale production of like, how do you bring water? How do you sell water? I mean,
yeah,
you
yeah,
have to,
no.
economically, it's not even feasible. You know, they have to really invent something new. It's like this shift can't happen. And I think that's why the media doesn't talk about it enough because if they start disrupting the whole system now without having a replacement alternative for it yet, um,
No,
it's going to
funny.
create chaos.
I'm gonna send you their account, their handle. It's a
Hmm.
company that a guy from Spain and a guy from I think Germany. They created a membrane made of algae, of seaweed that is compostable for water container, they're like now they're mass producing it. So it's
Wow.
like those things, one should invest on those things,
Yeah,
right?
no kidding.
Because they're packaging food, they're packing water. Actually, in the New York Marathon, they were giving them out. They were like little packages of this membrane with water or electrolytes, and they ate it. So you can eat it also because it's made of algae.
What?
Yeah, it's
So you
amazing.
finish drinking your water and then you eat the bottle?
You pour the whole thing in your mouth.
It's like reminds me of the guacamole hat. You just eat.
It's
Yeah.
I mean, but things like that,
Yeah.
people are finding solutions for that, right?
Mhm.
And but the industry doesn't or invest on it. They don't think it's
Well,
again
because it's
well,
because it's disrupting a lot of other powerful people. You know, money talks. I mean, for every one lobbyist for that, there is 100 lobbies for the other companies. So that's an uphill battle, and I think us as people can do something about it by pressuring our constituents and pressuring our government to pull through with these changes. Otherwise, I don't see it happening in a short period.
yeah. I was looking for the link, but I'm going because I found it so interesting, and then they won so many awards now for this creation. So
And any other suggestions on avoiding hormone disruptors?
I mean,
Like, what are
we
you
talk
doing?
about organic food, right, and non-organic, and people say, "Oh, it's not healthier." But I mean, pesticide-free
Hmm.
it's healthier, right?
Start
Because it
off with
doesn't,
that.
it's not
Easy.
up with that. But that's why that time, I mean, I went to a farm one day, and the process to not have pesticides in the crops is so detailed, and that's why it's so expensive to really, it's
Yeah.
again, it's cheaper to have the mass
Sure,
production
sure.
and just swipe them with pesticides, right? But avoid eating the skin of fruits and vegetables, right? Because that's where the pesticides morely condense. Um, buying from your local farms, also grass-fed meats, wild caught fish. Those are other things. Nothing that is farm. That's another important thing because you don't get those hormones for the mass production.
Mm-hmm.
Pasture raised poultry, pasture raised eggs. So there's little things that you can do that if you put them together, they impact.
Mm, I know. So thank you so much for that because I think I feel like personally, even though I knew a lot of the stuff, I feel so overwhelmed,
Yeah.
and I wanted to leave this conversation out on a positive note, um, and not on a doomsday note. But all of these
Well,
things we've talked about, they are true. So someone needs to bring awareness to these things. First, we have to acknowledge that issues exist so we can make changes, right? I mean, we have to talk about it. Like, if we don't talk about it, who's going to talk about it?
exactly. And I think it's not a doom. It's where we are right
Yes.
now as a country, in the 2025, we live in an
I think
industrial,
world, not just the country,
yeah,
everywhere.
we live in an industrialized world, right? We have all
Yeah,
this technology. We're living smarter, but it comes with some consequences,
100%.
right? And I think you having the education about how much you can control and what you can control is our best way to trying to get out of this in a good way, right? And live healthy.
And it's empowering. It's
It's
empowering.
education. Yeah, you have
Yes,
to educate
yes.
yourself, and that's your biggest weapon against food industry and just industrialization of itself. We cannot
100%.
say, oh, we're victims of our society, of where we live right now. We have some power, and the way that you can control and regain power is with education.
100%. And to that point, kind of like to end our conversation on that note, if someone listening to this entire podcast who feels really overwhelmed, ashamed, or lost, or helpless, what's one thing they can do today to just take back control of their health? Like, where would you have them start? And I know you talk to hundreds of patients and literally give them that advice. But for our audience here, um, what would you say that one thing would be where they would start?
I would say three things.
Okay, three things. Fair.
One, build muscle.
Hmm.
If you build muscle, muscle is an endocrine organ too.
Hmm.
It releases hormones, myokines. Muscle is your best anti-inflammatory organ that you have in your body. And if you're building muscle, you're losing body fat. We don't say that by losing body fat. By you losing body fat, you're not gaining muscle. But if you concentrate on one thing and that's building muscle, you drop body fat. So you're already in a metabolic, healthier state,
Hmm.
right? Second, get rid of plastics
Hmm.
as much as you can, right? And third, educate yourself.
Hmm. Hmm. Thank you. This was I think now it comes down to execution, and I really hope that um, the audience takes this to heart. And thank you so much for sharing your knowledge, your story, your compassion. I feel so much enthusiasm and sincerity, and every time you talk, that is inspiring to me as someone that has been on this path for several years now. And for those listening, guys, health isn't about perfection, okay? It's about reclaiming control over your
Mhm.
life with the tools available to you. And if you've been judged, dismissed, or just frustrated with your weight journey, know that science is on our side, and support is out there. And um, for those of you who are in the New York City area, but I know Dr. Salas-Whalen, and she also does virtual consultations and calls. Follow her online, share this episode with someone who needs to hear it. And we will put her information in the caption below. And yeah, until next time, stay curious, stay strong, and keep pushing forward. Thank you, Rocio. It was uh, such a pleasure to not just get to meet you, but to get infected by your passion for what you're doing. And I can't wait to read your book. And I hope that I'm pretty certain it will become a bestseller, because I don't think there is any more pressing and important topic than this in our society, um, than it's ever been. So thank
Thank
you
you.
for all you do, and keep inspiring our colleagues and keep pushing forward.
Thank you. Thank you so much.
Thank you so much. All right, guys. I hope you enjoyed this podcast. Please leave me a review so others can benefit from this episode. And also, you can on Spotify leave comments down below, and I'll be happy to respond to them. And yes, until next time, happy Memorial's Day. Bye bye.